Perfect. Okay, as you guys are all aware, we deal with a lot of resistant organisms in our ICUs. Especially now, we're seeing much more uh, use of broad spectrum antibiotics. And because we're doing that, uh, we saw this during the second wave of COVID when it really hit India. People were dying not from COVID, but from the multi-drug resistant organisms that were being produced because we were using so many antibiotics inappropriately. So I think one of the things we want to cover today is um, we want to understand what antibiotic we want to use and why we want to use it and what type of effect are we choosing to get. And it's going to be very important that you guys think along the lines of don't just do things because this is the way we've done them. Try to understand the reasoning behind our use of antibiotics. And here's the thing. Your empiric antibiotics, we start, empiric antibiotics, broad spectrum, and then we tend to leave these antibiotics on forever. And you'd be amazed how much people just don't pay attention to how long an antibiotic has been on. So we have to really be thoughtful about that. Next slide. Okay. Now, you're going to hear me tell you the earlier we start an antibiotic in an infection, the better it is for the patient. Very true. Um, and if we start the appropriate antibiotic, then it's better for the patient because if let's say I give an antibiotic that doesn't cover the bacteria that's causing the problem, then what you're dealing with is even if you change to an appropriate antibiotic after the fact, your mortality rate is still going to be elevated as compared to if you gave the right antibiotic. So it behooves you to give as broad a spectrum of antibiotic coverage as possible initially, but then you want to narrow it down because if you don't narrow it down, you're going to get in the next round, you're going to see multi-drug resistant organism that's going to come at you. So you have to be thoughtful about this. Now, unfortunately, our colleagues, the surgeons and the internists and people who are working with us are not as thoughtful about selection of antibiotics and duration of antibiotic therapy. And that's very important. So we're going to talk about that. Overuse of antibiotics in non-infectious settings. Fever, for example, in the ICU, 50% of the time, fever in the ICU is not related to infection. So what you must decide is this sepsis or is this just SIRS? Is it a systemic inflammation that you're seeing a manifestation of the fever? Or is it really infection? If it is, then treat it. But if it's not, back off. So you're going to have to be able to tell me whether this is prophylactic, whether I'm trying to prevent infection. It's empiric, where I'm starting an antibiotic because I believe there's an infection, and or whether it is therapeutic and I'm targeting a specific bacteria that I found or that I think is causing the problem. So you must think about it along those lines. And not all broad spectrum antibiotics are equal. And you have to think in terms of, is this a hospital acquired type of infection? Now, in some of our hospitals, we are now being asked to take over patients that are becoming critically ill. But if they've been in the hospital for, let's say, 3, 4, 5 days, and they're, let's say, post-op day 2 or post-op day 3 post-surgery, um, you're going to see this all the time. And if you're looking for where the infection is coming from, um, the, we used to have a rule. If you're going to try to steal money, where's the best place to steal money? A bank, right? Go where the money is. That's a rule you should follow even in the ICU. If a patient's been operated on, where is the most likely place you have infection? Where he got operated on. So if they got operated in the belly, guess what? That's where the infection is until you prove otherwise. Don't worry about the infiltrate in the lung. The infiltrate in the lung is not your problem. It is the belly until you prove otherwise. So you have to really think. It's not just about antibiotics, but it's about organizing your thought process to decide where your infection is and what you're up against. Okay, next slide. Okay, so once you suspect an infection, then you're going to try to decide, okay, what antibiotic do I want to use? So where's my source of infection? And, oftentimes people tell me, well, we grew MRSA out of the blood. Okay. Did it come from a line? Did it come from the lung? Did it come from the belly? Where did it come from? It didn't just show up in the blood. It had to come from somewhere. So you have to figure out where it came from. And how sick is the patient? If the patient is really sick, you may choose to use a bigger, broader spectrum antibiotic like a meropenem as compared to using something like a piperacillin tazobactam. Piptaz may be useful in a less severe infection, but if it's a more severe hospital-based infection that you're seeing, it's a big, nasty gram negative. There's a 30% improvement in effectiveness of getting patients out of such an infection using something like a meropenem as compared to using a piptaz. So you have to think along those lines. The other thing that I see a lot of, even in American hospitals, but more so in Indian hospitals, is that antibiograms need to be looked at. We have to convince our colleague hospitals, especially the microbiology section, that we need some antibiograms to look at what kind of resistance are you seeing in your area. For example, I'll tell you, in my hospital in Staten Island, where I used to work, clindamycin had about a 50% resistance rate to MRSA. So if we saw MRSA, we did not use clindamycin simply because we knew that it was going to be resistant. And we would automatically go to a vancomycin or something of that nature. Now, I still used clindamycin to clear the exotoxins, but I don't use it for the antibiotic effect. It's more to clear exotoxins. So again, you have to kind of think about what you're using each thing for. And as you're thinking through, another example, tissue penetrance. When we talk about like anaerobic coverage, right? You can have anaerobic infection above the diaphragm and below the diaphragm. Usually, if it's above the diaphragm, we like clindamycin because clindamycin has a better tissue penetrance above the diaphragm. Let's say you have a anaerobic infection in the face. That would be better covered by clindamycin as compared to a metronidazole. Metronidazole would be better coverage below the diaphragm. So these are the kind of little things that you have to be thinking about. Unfortunately, our surgical colleagues and even to a certain degree, our medical colleagues don't always think about tissue penetrance. You on the other hand, that's our job. So we have to think about that. The other caveat I will give you is for gram positives. We'll get into gram positive treatments, but vancomycin, while it's terrific for clearing the blood of gram positives, it's not so good at tissue penetrance. So if you've got, like, let's say a lobar pneumonia and it's MRSA, you may choose to use something like a linezolid as opposed to a vancomycin. So you're going to have to think about what you want to use. Okay. Next slide. Okay. This is older. People have kind of gotten away from it and more towards SOFA scoring, the sepsis associated organ failure scoring. But this is still useful from the standpoint of to show you that 50% of fevers in the ICU are not related necessarily to infection. Okay. If you have sepsis, if you believe you have sepsis, you just need SIRS plus a compelling reason for sepsis. Now, if you look, I know it's hard to read. I'm sorry about the slide, it's kind of small. The four criteria for SIRS are heart rate greater than 90, temperature greater than 38 degrees centigrade or less than 36. You notice it's on both sides. You can be hypothermic and be septic or have systemic inflammation. So you have to think along those lines. You notice blood pressure is not a criteria for SIRS. White blood cell count and respiratory rate round out the four. But blood pressure, there's no real part of SIRS that includes blood pressure. So you got to think along those lines. Again, please think about that when you're looking at your patient. Think about what are you dealing with, okay? And again, severe sepsis is sepsis plus at least one organ failing. And septic shock is where you have to put a medication to hold up the blood pressure. You can't just resuscitate them with fluid out of that hypotension that you see from sepsis. Next slide. Okay. So this is where the Surviving Sepsis campaign really came to full bear, if you will. We had a few patients in the New York City area that were young and they succumbed to infection. And what people started looking and saying, hey, look, we have to have a better way to think about infection, and we have to have a better way to treat our patients. And this first hour sepsis bundle came into play. And the sepsis bundle includes looking at a lactate level, looking at obtaining blood cultures. Now, you don't necessarily need the lactate level or the blood cultures, but appropriate antibiotic, the broad spectrum antibiotic, as early as possible. And that, there's an argument whether you can get it in within 1 hour, within 3 hours. Let me tell you, some of the data from the Canadian critical care guys, they're the ones who started all this stuff. These guys actually looked at hour by hour. And what they found was that if you could start it sooner, an hour sooner, you had better survival. So a big broad spectrum antibiotic as early as possible. If you suspect sepsis, empirically just start it. And then we can deal with, if you don't believe it's sepsis after 48 hours or so, okay, you can turn off the antibiotic. Again, understanding what you're up against and what you're thinking about. The next thing was that, people started speaking about fluid resuscitation and sepsis. We got into a lot of arguments over this because people were looking at oxygen transport. And what they found was that clinically, if the patient looked okay, their oxygen transport could still be poor. And those patients ended up not surviving. So what they found was that if we resuscitated toward oxygen transport goals, these patients did better. What they also noticed was the difference between resuscitating clinically and resuscitating to oxygen transport goal was simply a matter of about 30 ml per kilo of fluid. So what the Surviving Sepsis people said was, okay, let's give that bolus right away. When they started giving the bolus, what they found was, and they repeated the test, the study again, what they found was there was no difference between the study group that was studying oxygen transport and the group that empirically got 30 ml per kilo. So what they said was, okay, fluid may or may not be so important. That's not true because you changed what the and I like to call it your control analogy, right? You're comparing to your control group. You just moved your control group closer to your therapy group. That's why there's no difference. But you've given that patient that much fluid. So you have to think about that. Now, if the patient has heart failure or something, then you're going to have to be a little bit more careful how you provide the aliquots of fluid. But if your patient does not have heart failure and they're in septic shock, then certainly giving the fluid bolus is very useful. And I think that's one of the things that we've really pushed on. The last thing that we've really pushed on is if you're going to use vasopressors for the hypotension, um, the best vasopressor to use is norepinephrine, NORAD. Okay, and I think most of you know that because that's what you've been using now on a routine basis. And the reason for that is that it turns out that it's probably the best one to raise the blood pressure and not really have as much of a, if you will, cardiac toxicity issue, the right heart, the stress issue that you see with other drugs like neosynephrine, phenylephrine, etc. So we don't use those anymore. We use more NORAD than anything else. So again, early on, this is the sepsis bundle. Next slide. Okay, so we spoke about starting our empiric antibiotic early. Next slide. This is an antibiogram. Okay, it's kind of a simple antibiogram, but it's still an antibiogram. Okay, what it does is on one side you have the different bacteria, on the other side you have different antibiotics, and you notice the various different percentages of sensitivity. So if you're going to select an empiric antibiotic, it behooves you to select an antibiotic where, let's say for the first E. coli that you're seeing there, you would like to probably take like a carbapenem, which is going to cover these guys, or you're not going to get as good a coverage with others. Now you can probably use piptaz, but again, that's 93%, so that's not bad. So again, you have to think along the lines of what's going to cover the proposed bacteria that I'm thinking about. Now, if you're thinking about a urinary tract infection, okay, you're going to be thinking gram negative. If you're thinking about a intra-abdominal infection, you're going to be thinking about aerobic gram negative and an anaerobe. So you have to think along the lines of what is your antibiotic covering? What are we missing? So next slide. Now here's the other thing in surgical patients, okay? If you go for more than 7 to 10 days on any antibiotic, please remember this, okay? That patient needs a procedure, okay? Do not leave the patient on antibiotics for more than that period of time. Now, if you're dealing with an osteomyelitis or something of that nature, the site of infection is going to play a huge role. If you have an osteomyelitis, there's an infection in, let's say, the sacrum because they developed a bed sore, okay? And that sacrum is exposed and they have infection there. And you want to make the argument that I'm treating an osteomyelitis and it's going to take a lot longer for me to treat that osteomyelitis. Okay, fine. I'll buy that argument. But you have to, if you're going to go more than 7 to 10 days, you got to give me a good reason why you're doing that. Now, here's the other thing. If you're starting empiric, usually by 3 days, you'll know what you're treating. Now, if it's an intra-abdominal infection, unfortunately, cultures don't always come back. Cultures get lost. I know, I've been there. Surgeons like to send cultures. They'll stick the swabs in. Lord knows where that culture ends up. Okay. But then, then the surgeon will say, oh, I sent the culture, but we never got it back. Okay. 7 to 10 days. Don't go more than that. If you're using your empiric antibiotics, don't go more than 10 days. By 10 days, if the infection is not clear, if the patient is not better, then Go looking. And where's the money? Where the surgeon was. The surgeon will say, they'll deny it. Oh, that abdomen is perfectly clean. Listen, go where the money is. I'm going to keep reiterating that. Okay. Now, if you're selecting antibiotics, the other thing always take in consideration is what's the renal function, what's the hepatic function. Do I need to dose adjust? Now, here's the thing with kidney function, remember, normal kidney function about 100, GFR runs anywhere above 120 ml per minute, right? So that's normal. And that's usually 35-year-old person, normal kidney function, everything is hunky-dory, great. As we get older, every decade we lose 10 ml per minute. So think about how much we lose in GFR. By the time your patient gets to 70, okay, you've already lost 35, you're already at 85 without the effect of hypertension, no diabetes, all these other things that can play in, okay, are not influencing anything, but your GFR is already down to 85. Okay, now on top of that, all the other medical issues that are kicking in, your GFR may be below 60. If it's below 60, for most antibiotics, you got to start thinking about dose adjusting. So you need to look, you need to see. And remember this, a creatinine of 1 in a 50-pound grandma, okay, or a 70-pound grandma, 35 kgs, okay, may not be the same thing EGFR wise as a 150 kilo, muscular guy, So a creatinine of 1, you really need to think about what is my estimated GFR. So think along those lines. That's going to be important. So again, now, next slide. Okay. Here's the other thing to think about. If you got a patient with a diabetic foot ulcer, okay, I see this all the time. The patient is septic, okay, but the blood flow to the foot is not really there. Okay, it's diminished because they're diabetic, they have peripheral vascular disease. Is your sepsis that is systemic coming from the foot? No, it can't. If the circulation can't get to the foot, the infection's not going to deliver that force back out. So remember that. Look elsewhere. If you've got a diabetic foot ulcer, you can use the biggest antibiotic you want. If it doesn't get down there, it's not going to help your patient. So that's the other thing you got to think in terms of. So you really need to be thoughtful about where my blood flow is going, where the infection is. You have to be thoughtful about the infection itself. Okay. If you're considering meningitis, well, kind of makes sense that you use an antibiotic that crosses the blood-brain barrier. Now, you can make the argument to me, well, Chandrasekhar, if we're dealing with meningitis, all meninges are going to be permeable to antibiotic. That's very true. Any antibiotic will permeate inflamed meninges. However, once the infection starts coming under control, just a little bit, then what happens? Then the blood-brain barrier comes up, and if your antibiotic doesn't cross the blood-brain barrier, that's a problem for you. So you have to think, does the antibiotic I'm choosing cross the blood-brain barrier? Is it like a third-generation cephalosporin? Is it, what type of antibiotic am I using? Am I using a first-generation? Neurosurgeons are some of my best friends, but I'll tell you, I had to change how they were thinking because they were using first-generation cephalosporins in their surgeries, in neurosurgical cases, and all of a sudden they would give cephalothin, which is a first-generation cephalosporin, to their patient before surgery, and I would ask them, "What are you trying to prevent?" "Oh, meningitis, of course." Well, if your antibiotic doesn't cross the blood-brain barrier, how are you going to protect the patient against meningitis? So you have to kind of have that discussion with them so that they understand. Please understand, not everybody is an expert in thinking about this. So you have to kind of nicely bring it forward. And that's how you got to think about it. Now, the other interesting thing you need to think about is how many bacteria are in that area. Let's say you have a obstructed urinary tract. Huh? Um, if you have an obstructed urinary tract and let's say the patient has a urinary tract infection, okay? There's a problem here because you may not be able to kill all the bacteria that are behind the obstruction because it's obstructed. There's a lot of bacteria there. When there's a lot of bacteria, your antibiotic efficacy may drop down significantly. Even if in the culture it showed sensitivity, it may not be sensitive in the patient. So you're going to have to, the term we used was, if you're building, developments in an area where there's a swamp, you have to drain the swamp in order to get rid of all the animals that are there, like snakes, etc. Right? So the only way you're going to get rid of all the bacteria is to make sure that that area is draining properly. And let's say if you have an abscess, you need to drain the abscess. You don't treat abscesses with antibiotics. You treat the surrounding cellulitis with antibiotics. So you have to keep that in mind. Next slide. Okay. And this is where if you have more bacteria present, you're going to have something called an inoculum effect. This is where your antibiotic won't work as well. Now, certain antibiotics, we don't get very high tissue levels for very long, and they go, but they work very well. Azithromycin is one of these examples. Azithromycin has terrific intrapulmonary penetrance. So the tissue levels of azithromycin in the lungs are very high, even though their serum level may be nothing. So this is called a post-antibiotic effect. Now, the MICs for this antibiotic in that area, the tissue level is very good. So again, that's the thing you want to think about. The minimum inhibitory concentration, usually your tissue level, you want about 4 times the minimum inhibitory concentration. So that's how you want to be thinking. So you have to pay attention to all this. Next slide. Okay. The other thing that you want to consider when you're starting your antibiotic is, if I give more of the antibiotic, am I going to kill more bugs? That's a very important question. If I don't, if it's not a concentration dependent killing, that means like gentamicin, amikacin, the aminoglycosides. Now, if I give more aminoglycosides, then I can kill more bacteria. So with aminoglycosides, we go with single day dosing where we can give 5 times the amount of a standard dose and just give it once a day. And what that does is it kills more bacteria. Fluoroquinolones and aminoglycosides, that works really well. Whereas antibiotics like vancomycin, checking a peak level doesn't make any sense with vancomycin because it's not a concentration dependent killer. It's a time dependent killer. So I have to get to steady state, which is over 4 times the minimum inhibitory concentration, and then hold it there. The longer I can hold it there, the more bacteria I'm going to kill. So you have to decide what type of antibiotic you're dealing with and how you want to dose your antibiotic. With vancomycin, remember, and any antibiotic, the first dose, I always like to say the first dose is free. What do I mean? It's not a cost thing that I'm talking about. I'm talking about toxicity. As far as toxicity is concerned, it's never the first dose that causes the problem. It's always the subsequent doses, right? But the first dose you can give empirically. So first dose you can always give. Whether the patient is in renal failure, renal insufficient, doesn't matter. You give your first dose. Then with the second dose, then you got to start worrying about toxicity issues. No, but for the first dose, you go ahead and give the first dose and you wait, and then figure out whether you can give a second dose or third dose or not. but you have to think along those lines. Next slide. Okay. The other important thing in antibiotic selection is, let's say you're in a movie theater, okay, and somebody yells fire, okay, and you're trying to exit the movie theater. If the movie theater has 3 or 4 exits, is that better, or is it better if you only have one exit? Well, if you have 3 or 4 exits, it'd be much better, okay? In the same way, when you're thinking about killing a bacteria, if you use an antibiotic, if you use multiple antibiotics, you want to use multiple antibiotics that can enter into the bacteria through different channels. Yes? So you want to pay attention to the mechanisms of action. You don't want to use 2 antibiotics that use the same mechanism. It doesn't make sense because you're going through the same door. Right? So, think of a movie theater. That's how I like to think about bacteria. So that's an easy way to envision how you're treating your infection. So think about it along those lines. Okay. Next slide. Okay. The other thing that we've really studied very carefully is how antibiotics become resistant. And, a couple of years back, Time Magazine had, instead of the man of the year, it was the bacteria of the year, and it was a resistant, multi-drug resistant Pseudomonas or something like that. And the emphasis in that Time Magazine article was that we were seeing more and more resistant bacteria. And how do we address these bacteria? And the most common mechanism is the last one. It's enzymatic inactivation of the antibiotic. That's how beta-lactamases work. So when we talk about beta-lactamases, if you're starting to see very resistant bacteria, start thinking about the more specialized antibiotics that we have. Start thinking about, and if by 3 days, usually once you start empiric antibiotics, if by 2 to 3 days you're not seeing improvement, you have a problem. Okay. And you really have to think in terms of, if I'm not seeing improvement by 3 days, then there's something wrong. Don't wait for the entire 7 to 10 days. 3 days, it's not working. So go back and look at your antibiotic. And when you look at your antibiotic, I want you to think in terms of, what are the holes? What is not being covered by the antibiotic? And what is the bacteria doing that is making it resistant to the antibiotic that I'm providing? So you have to think along those lines. Think ahead. Don't wait until 7 or 10 days goes by and the patient is deteriorating even more. The one lesson that I will teach every ICU doc and nurse that I come across is, the difference between what we do now and what we did 20 years ago is not just catch our patients when they fall, but predict when the fall is going to come so that the degree of fall is not as much. Next slide. Next slide. Okay, so antibiotic combinations are coming into play. There are advantages, there are disadvantages. Now, you may be able to use less of an antibiotic like a aminoglycoside, amikacin, gentamicin, those. You can use less of an antibiotic if you're looking for synergy. Now, I want you, when you're using an antibiotic, to be able to explain why you selected that antibiotic. Don't just say, well, we think it's this, we're kind of throwing this empirically. Okay, but also if you're using combinations of antibiotics, what are you using this antibiotic for? If you're using the clindamycin to clear the exotoxin, okay, that's good. If you're using the combination of an aminoglycoside and a cell wall agent like a carbapenem and an aminoglycoside. Why are you using the aminoglycoside? Well, I want to get that synergistic effect. Okay, good. So you're thinking along the lines of why you're using what you're using. Huh? And there may be potential antagonism. You have to look for that. You have to see how certain antibiotics work with other antibiotics. And if they don't work well, you may want to switch to another antibiotic. We have several for that we can use. So think along the lines of what I'm going to use. Okay, next slide. Now, again, we have cell wall agent, aminoglycoside, beta-lactam plus beta-lactamase inhibitor. That's piptaz, right? Those kind of things. We're also using antibiotics that have sequential targets. We have come a long way in developing different antibiotics for different purposes. Now, granted, we don't have the breadth of antibiotics that came out in the 1990s. Now, in the 1990s, we had a flood of antibiotics that came out that covered gram negatives, gram positives, anaerobes, all these different antibiotics. Then, after that, the pharmaceutical companies slowed down, and they only have a few that came out. So we're kind of stuck with these resistant bacteria that we have to think along the lines of what am I going to do next? Next slide. Okay. When we talk about beta-lactam antibiotics, okay, we're talking about penicillins, the various different penicillins that we have. Remember, penicillin is something that you can still use for streptococcal infections and Clostridium infections. So think about that. Now, with Clostridial infections, you have to talk to your surgeon. Okay, if you have a synergistic infection with uh, uh, anaerobes and aerobes. Now, remember this, anaerobes can't make collagenases, so they don't go break through tissue planes. Aerobes do. And the way to remember this is, there was a whole series of experiments on appendicitis. Okay. They reproduced appendicitis in laboratory animals. What they do was they ligated the cecum and punctured it, and then they got peritonitis. But the important thing here was when they covered the aerobic gram negatives, all the animals developed intra-abdominal abscesses because they didn't cover the anaerobes. When they covered all the anaerobes, every animal died because the aerobic gram negatives went systemic and they killed off the. So what's the issue? The issue is anaerobes cause local toxicity. Where does that change? It changes when you start hitting tissue planes and the aerobes and the anaerobes start working together. That's what we call synergistic gangrene, right? The necrotizing fasciitis, the necrotizing myositis. These are where the aerobes and the anaerobes are working together. If that starts happening, you got to talk to your surgeon. Your surgeon needs to go in there and remove all the dead tissue and open everything up. Okay. If the patient has a bed sore and they have pus coming out from the bed sore, trust me, no antibiotic in the world is going to help that patient without somebody taking a knife to that area and removing all the dead tissue. Okay. They have to work with you, and you have to sit with them and say, boss, I need your help. You got the treatment for this is cold steel, not all the antibiotics in the world. So that's the kind of thing you got to think in terms of. Next slide. Now, we have different types of penicillins that we have available, the carboxypenicillins, uridopenicillins. The reason I put these out is because we have a ton of different antibiotics that we can use. You need to be aware of what is usable, what is not, what is user friendly, what is not. So you need to think about that. Next slide. Okay. Beta-lactamase inhibitors that are combined with, the sulbactams of the world, the clavulanic acids of the world, the tazobactams. the avibactam. So these are the kind of things that we use in combination with penicillins. So understand that. And sometimes these penicillinase inhibitors actually end up killing the bacteria better than the penicillins themselves. This is what we're seeing with the resistant bacteria, like the Acinetobacters of the world. So this is something to think about. Next slide. Okay. Cephalosporins, remember, first generation, good prophylactic. And again, if you're going to use prophylactic antibiotics, no more than 24 hours, please. No more than 24 hours in surgical patients. I know the surgeon will say, oh, no, 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 I have a graft in there. No more than 2 days, 48 hours period, end of story. Okay, even that is being generous. Okay, if you leave the antibiotic on, I guarantee you in 1 week you're going to be seeing a multi-drug resisting organism coming back at that patient, and then the surgeon will turn around and say, help me. And you can't accept that. You have to kind of keep sitting with the surgeon and say, sir, we have to turn it off. Sir, we have to turn it off, because it's prophylactic. Okay. So it's important that we think along those lines. The second generation cephalosporins, remember, anaerobic coverage is provided by second generation cephalosporins only, not first generation, not third generation. So you have to keep that in mind. So if you're not providing anaerobic coverage, let's say you're covering an intra-abdominal infection, simply providing cephalothym will not cover your intra-abdominal pathogens, the anaerobes. So please remember that. So if you're prophylaxing, you want to prophylax with anaerobic coverage. So think about that. Next slide. Okay. And again, second generation cefuroxime is almost like a third generation. This is what we use for otitis media, no, in children. That's where claim to fame came from. It protects against meningeal infection. So again, something to think about. Next slide. Okay, and again, third generation, no anaerobic coverage, but they do penetrate CSF. So if you got neurosurgical patients, and if you want to provide prophylaxis, ceftriaxone would be a good choice. So again, something to think about. Next slide. Fourth generation cefepime, we use this for lung infections. So again, something to think about. But remember this, it doesn't cover enterococcus, it doesn't cover MRSA, it doesn't cover listeria, it does not cover anaerobes. So remember that. So keep that in the back of your mind. If you're starting an antibiotic and by 3 days you're not seeing the effectiveness of the antibiotic, either A, you don't have an infection, or B, your infection is outside the spectrum that is covered by your antibiotic. So you have to think along those lines. Okay, next slide. Again, carbapenems, very useful against ESBL, right? Extended spectrum beta-lactamase producers. Carbapenems are the treatment of choice. So again, you have to think along those lines. If you suspect an ESBL gram-negative, you need to think about using meropenem or imipenem. We don't use as much because of the seizure question that came up. We use, meropenem a lot more. Next slide. Remember, here's the other lesson that I want to get across to you guys. Not all carbapenems are the same. And sometimes drug companies will say, well, doripenem is just as good as meropenem. It may be, it may not be. Okay. The worry for you is, one, and you can utilize, even though we're in India, you can utilize the Food and Drug Administration approvals that are done in the United States as a means to see whether this coverage is there or not. Okay. If the coverage is not there, the FDA approval won't be there. Doesn't mean that we don't use it, even in the United States, that we don't use a certain antibiotic because the FDA approval is not there. We use that, that's called off-label. And we can do that. But we have to understand how effective that antibiotic is. And the analogy I give you is, if you're running at somebody who's shooting a machine gun at you, the last thing you want to do is you run up to them and you figure out that your knife is made out of rubber. That's not what you want. You want to make sure that that knife is real, because if you know, and the other adage my mentors used to use is never use a knife to get into a gunfight. That's very true. So you have to think along those lines. Is my antibiotic going to save this person's life? And here's the other thing about dosage: give the appropriate dose, okay, based on their height, weight, etc. Give the appropriate dose. Don't underdose because, oh, this patient is frail, they may not know. Give the appropriate dose. If you're going to give a meropenem, give the appropriate dose of meropenem. Don't underdose, because if you underdose, you're asking for trouble. Okay, next slide. Okay, polymyxin. It's interesting because we've come back to polymyxin. And the trick with polymyxin is there's a lot of nephrotoxicity that's involved here, right? The thing with polymyxin is if you mix the polymyxin in normal saline as opposed to D5W, most hospitals will mix, the pharmacist will mix polymyxin in D5W. You'll get a hyponatremia and you'll think that's kidney toxicity. It's not the case. It is because you're mixing it in D5W. Have them change it to normal saline. That will help some of the toxicity issues. The other thing is remember, when you give polymyxin, you're giving almost a liter of fluid to the patient. Okay, it's not a small amount of fluid. So you have to keep that in mind. And here's the other lesson that, I was taught at a very young age. As you start resuscitating your patient, as you're working on your patient, if you don't count every drop of fluid that goes into the patient, okay, either it has to come out by, it has to come out by the patient urinating it out, or the patient's going to die with it. Remember that. So you have to keep in mind how much is going into the patient. This is why ins and outs are so important. And antibiotics are mixed in a lot of fluid sometimes. And you have to keep that in mind. Okay. But acquired resistance to polymyxin is rare. I mean, you'll see the intermediate sensitivity. It may be that your polymyxin is not getting to the area of infection, like the lungs. So you may have to aerosolize. So think about aerosolizing on top of your intravenous. So think about that. How am I delivering the antibiotic is also the question. Now, aerosolized antibiotics by themselves are not safe, okay? But if you do it in combination, it may be okay. Aztreonam. Now, if you have a resistant bacteria that is an extended spectrum beta-lactamase, or a very resistant, let's say, Acinetobacter or something like that, think about using Aztreonam. Very effective against gram negatives, aerobic gram negatives. It's got terrific activity. The resistance is very minimal, but it's very expensive. So you got to remember that. Next slide. Okay, aminoglycosides, we use it for aerobic gram-negative infections. Do we use them in combination for some other gram-positive type infections? Sure, but for the most part, we're using them for aerobic gram-negative infections, okay? And that's important to remember. Next slide. Okay, and the toxicity you guys are all familiar with. I'm not going to waste time. The neuromuscular weakness, by the way, if you're using this is the reason we were talking about paralytics yesterday. If you use paralytics, if you use steroids, if you use aminoglycosides on top of that, you will have your patient develop neuromuscular weakness. So keep that in mind. So think about that in the back of your mind. And again, it may be that you have to give them a little extra calcium. Maybe it will help. But a lot of times this just takes time to clear. So that's something to keep in mind. Next slide. Okay. Fluoroquinolones were the replacement for aminoglycosides. Remember when we first developed fluoroquinolones, they were supposed to be the oral equivalent for aminoglycosides. So aerobic gram negatives were what they were supposed to be given against. Now, next slide. What you guys are familiar with is ciprofloxacin and levofloxacin. Huh? Ciprofloxacin, I will tell you, people, this is the classic example I like to use about an antibiotic that does not give you enough tissue penetrance in the lungs to be 4 times the MIC. So what happened? Well, we were treating pneumonias with ciprofloxacin, right? This was in the 1980s and 1990s. By 2000, we found that all these pneumococcus were becoming resistant to ciprofloxacin. And everybody asked, why? And the reason was, here's the thing, okay? The tissue level in the lung for Cipro and for, by the way, for levofloxacin as well, is very close to the minimum inhibitory concentration. And because it is, you're going to get resistance. And levofloxacin, I don't know if you guys actually read previous guidelines for treatment of community-acquired pneumonia, but it used to be that we were using 500 mg of levofloxacin every day for community-acquired pneumonia. Now, the guidelines say we have to go up to 750. And the next set of guidelines, we may not be able to use levofloxacin at all because the tissue levels aren't good enough to support that treatment, and that's where you're getting resistance from. Next slide. Okay.
Yeah, Dr. Chandrasekhar, I have a quick
Yeah.
moment, Dr. Sanu here.
Sure.
So, yeah, well, one more point about quinolones, particularly in India. It's not really preferred much even in pneumonia for a couple of reasons. One, existing studies, there aren't that many, show that the resistance levels found in this country is pretty high. Some studies cap it up close to 60 to 70%. And also, it's one of the first lines of first line medications for MDR tuberculosis. So we would like to preserve quinolones as much as possible and use an alternative. And
Right.
yeah.
And I agree with you. And the Acinetobacter infection levels shot up when we were using fluoroquinolones aggressively. So one of the things that we've kind of from even our standpoint in the ICU has been, we avoid that. But you will see some surgeons like to use, especially if the patient has a penicillin allergy, they'll use levofloxacin and metronidazole as a combination for their intra-abdominal prophylaxis or intra-abdominal treatment. You have to step in and say, perhaps we can use, if the patient has a penicillin allergy, if it's not anaphylaxis, the probability that they'll be allergic to meropenem or even piptaz is pretty low. So, we can use piptaz. It's not a problem. We have to talk to our surgical colleagues in a nice way and kind of get that communication going. The communication is going to be the biggest issue for us. And like I said, as you're guiding antibiotic therapy, you're the one that's thinking about this. This is your home turf. Please understand. And like Sanu said, I mean, if you don't think about it, certainly your surgical colleague is not going to pay any attention to it. They're just going to say, okay, whatever you want. Or they'll say, well, this is what I've used in the past. What you have to do is kind of guide their thinking and kind of explain why you would like to switch to this or switch to that. So this way, that's how you're going to move it forward. The moxifloxacin is useful for intra-abdominal infections, very useful. Not as good for complicated UTIs. So something to think about. Next slide. Gatifloxin, I don't know if it's available in India, but gatifloxin, it was a very effective gram-negative killer. But the problem was we were seeing hypoglycemia in our elderly patients. So it was a real problem, and we pulled off and we stopped using Gati. Next slide. Okay. Metronidazole, terrific drug. But remember, tissue levels below the diaphragm are awesome. Above the diaphragm, not so good. So if you're dealing with an anaerobe in the upper part of the body, think about clindamycin. Don't go with metronidazole. Yes, it covers anaerobes, but the tissue penetrance above the diaphragm is pretty low. Next slide. Okay, vancomycin. Vancomycin is terrific gram-positive killer. But here's the thing with vancomycin. Tissue penetrance for vanco is pretty poor. So if you've got a methicillin-sensitive Staph aureus, my suggestion, switch back to a nafcillin, oxacillin, those kind of things. If you're dealing with an MRSA and you know it's coming from the lungs, it's a lobar pneumonia or something like that, switch over to a linezolid or something of that nature. Vanco is good for clearing blood. But if you notice an infection in the blood, I'm going to ask you again, where did it come from? Did the bloodstream infection come from a line? Most common source is a line, central line. Or did it come from the lung? Did it come from the urine? Did it come from the abdomen? Where do you think it came from? And you're the best one to be able to tell that, okay? You have to tell me, because there is no one else that's going to be able to tell that. Now remember, the surgeon, any surgeon, orthopedic surgeon, if you say, well, that hip wound looks a little infected, he's going to say, oh, no, it's clean. This is normal. So you have to be the one that kind of is the untainted investigator. Denial, remember, is a very strong emotion among all doctors, not just surgeons. I'm a surgeon, so I can tell you that. So, having done surgery for 25 years, I can tell you, denial is a very strong emotion. You have to overcome it. So again, that's something to keep in mind. Next slide. Okay, clindamycin. Again, cefazolin is certainly a very good choice for methicillin-sensitive staph, no question. Staph, strep, first-generation cephalosporins are terrific. They're good coverage, and you can use them. If it's not MRSA, if it's MRSA, you're stuck. You have to think along those lines. Clindamycin, check the sensitivities, please, at your institution. Look at that antibiogram. If you don't have an antibiogram at your institution, ask the institution microbiology department, please make an antibiogram. Okay, they will be able to create it. It's not that difficult. Any microbiologist can do it. They're very good at it. All you have to do is kind of, ask them, please, and they'll help you. Next slide. Now, linezolid, terrific tissue penetrance in the lungs. Not so good in the abdomen, but you can use it. If you've got an intra-abdominal infection, again, you may want to think along the lines of, it may not be a methicillin-resistant Staph aureus. It may be a more sensitive issue. So you may want to be thinking along the lines of a meropenem or something of that nature. So again, think about that. But for the lungs, certainly linezolid should be under consideration. Next slide. The quinpristin, dalfopristin, the streptogammon antibiotics, very good gram-positive killers. Not useful against faecalis. Now, here's the thing about enterococcus. If I see enterococcus faecalis, I won't use the streptogrammins, but I'm a much happier person when I see a faecalis, because faecalis, usually you can treat. Faecium, on the other hand, I will go to streptogrammins, but faecium usually is a bad result. Faecium is a nasty bacteria. And, and this is usually vanco-resistant Enterococcus faecium. So we call it VRE, and it's a horrible little bug. Now, in India, we are seeing some vanco-resistant Staph aureus. Be very careful in this setting, okay? Go to your bigger guns. Use your linezolids, use your streptogramins. Next slide, we have another different one. Hold on, next slide. Okay. Trimethoprim sulfa is actually a reasonable choice for aerobic gram positives and aerobic gram negatives. Next slide. Okay. Daptomycin, very good against gram positives, a big time gram positive killer. So think along the lines of big time killers. If you're seeing a true pathogen like Staph aureus, watch out, be very careful about how you want to deal with it. We'll pull up here. We'll finish up on surgical infections on